Okay, so everyone, we are live now, and with all your concern, we are starting today's session. So, good afternoon and a warm welcome to all the dignitaries present here. Myself, Rupsha from ClearNet, assigned as a session assistant to ensure a seamless experience. ClearNet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that ClearNet is the digital partner of this event organized by National Neonatology Forum, and the topic of today's session is NNF course on ventilation day 15. So let's begin today's session, for which I would like to hand over the session to Dr. Kunal sir. Over to you, sir. Please proceed with your talk.
So, thank you so much, Rupsa. So, it is a great pride to have our President-elect, Dr. Somsekhar sir, with us. Thank you so much, sir, for joining with us. And we have today a very important topic, that is KMC and its impact on our brain. So, this is our Neonatal Pathshala series, and we'll be doing it on every Wednesday. So, I would request now Shwetal ma'am to say a few words.
Thank you so much, Dr. Kunal. This session is very important, and I had heard partly this session. It was at night 10:30, and so I thought it should be shared with all the NNF Gujarat member, and hence I have requested Dr. Somsekhar sir to share the recent research or whatever the review of literature and what Karamsat team is putting their efforts to see the impact of kangaroo mother care on KMC. So thank you so much, Dr. Somsekhar sir, for agreeing to deliver the session at the platform of Neonatal Pathshala. And I would like to ask Dr. Vishal to introduce us expert faculty.
Thank you so much, ma'am. And as we know, today's topic is KMC impact on preterm brain or any brain. So for that, we have our. I would like to say that is icon of Gujarat NNF right now. And am I audible? Sorry.
Yes, yes, you are audible.
Yes. Okay. I thought. So I would like to introduce Professor Somsekhar Nimbalkar, sir. I welcome you, sir. He does not need any introduction. I think it will take another 30 minutes to introduce, all his achievement and everything. But I would like to say some highlights of them. So, sir, currently working as a professor and head of the Department of Neurology, Bhayakaka University, Karam, sir. He is like our proud moment for us that he is a president-elect 2026 for NNF India. He is a editor-in-chief, Journal of Neurology, Joint Secretary, KMC Foundation in India, Chairperson of 2023 IAP Medical Education Chapter. Also, he is a national coordinator for IAP NNF NRP program from 2020 to 2024. Most importantly, he is an associate task force member, NLS, International Liaison Committee of Resuscitation. Very few people can achieve this achievement. So I would like to congratulate sir for that. Again, he is one of the first the first DM course in neurology in Gujarat from 2021, and he has like multiple oration and publication, more than 140, 250 plus research presentation, plus 50 plus in pediatric association societies. So I welcome you, sir, and it is proud to introduce you as a moderator. Thank you so much. Over to you, sir.
Thank you, Dr. Vishal, for the kind introduction. I would like to thank Dr. Shwetal and Dr. Kunal for the invite. I would also recognize the people on the platform. Dr. Vishnu, but thank you for joining, sir. It's great to have you here. I will share my slides now, and normally we kind of finish this presentation in 1 hour, but actually I would like to take a little bit a longer time for this particular presentation. So I hope you can bear with me. Maybe people might leave. This is a presentation that we did at the Neonatal Brain Society seminar last week, I think maybe 2 weeks back. And this was mainly related to KMC in the brain. And so me and Dr. Aditya Bhatt, we did the presentation together. Today, actually, Dr. Aditya is answering his exams. his 6 monthly exam, so he's not being going to be there, and I'll be presenting the same slides. So thank you everyone for joining. As you can see, the topic of the webinar is impact of KMC on the brain, and there's a slash and there is S. So even for the Neonatal Brain Society webinar as well as for this Gujarat NNF, the flyer, I don't know, people have removed the S and the slash and they have just kept impact of KMC on the brain, which is not what I wanted to do, which is not what I will do, because we are not talking only of the brain of the baby, we are talking also of the brain of the mother and the father, which kind of changes. So the impact of KMC does not happen only on the brain of the baby, but also in many ways it affects the mental health of the mother, and possibly the way the brain functions or the interpretation of newborn care or child care of the parents. So we'll discuss that over the next more than an hour or so. So we will do that. All right. So we will discuss the growth of KMC in the last 5 decades and discuss some of the studies that we have done, and discuss a whole lot of other studies that we'll be doing. So this was something which I picked up, I think 1 year back or so, where I looked at publications related to KMC over the last maybe 45 years or so. As you can see, from 1999 to 2000, almost over a decade or so, there are probably not more than 35 publications. All of them actually case reports, some and just 2 or 3 are RCTs, of maybe 4 are RCTs. So not many publications in the first 10 years. KMC started somewhere in 1978, 1980, around that point of time. So from maybe 1975 to 1990, 15 years or so, there were hardly any publications. Basically, what there was UNICEF was promoting it because of the increase in survival of KMC in Colombia, and it was getting promoted in the South American region of the WHO. And then there was research that started somewhere in the 90s, and some publications started coming out. And as I'll share the research that was significant later on, the publications kept on steadily increasing. As you can see in 2020 and 2022, in that time, there's a jump in number of publications, almost 157, 122 per year. So which is a significant number of publications in a year itself. So why is that important? I will discuss that in a bit. So this is the timeline of KMC at the website that is given down. You actually can see it happening across all those years. So in the first initial period, there was just the practice of KMC. There was really no evidence that it is useful, etc. And it was found to be useful both by nurses as well as doctors. And so generally, when we talk about evidence-based medicine today, if you start anything, people will say, what is the evidence? What is the evidence? So these people, when they did the practice from 1975 to almost till around 1990 or 2000, there was no great evidence available, at least for the first 15 years. But they kept on persisting on using KMC, despite no great evidence for its usefulness, except their own local experiences or what data that they had that patients improved, the abandonment of babies reduced, and so based on that they continue to practice it. So that is something which we should understand when we want to talk about evidence-based medicine all the time. And actually I do that quite a lot, but there are many practices which might be new, which might be good, which might not have a lot of evidence, but which are useful. But what commonly happens in most places is people tend to continue to use those practices without much evidence for relatively long periods of time. In fact, most of the neonatal neonatal drugs used for treatment of neonatal seizures, when we started using them, did not have a lot of evidence, and evidence is being built only in the last 10, 15, 20 years or so. So there are many such practices across medicine, not only in neonatology, which may not have a lot of evidence. But what this foundation basically did, the KMC Foundation, is they began doing proper randomized control studies somewhere around 1990 onwards, 1993 onwards, which has built a large evidence base, and we shall see how that evidence has been built. While we talk about evidence, till 2011, so the practice began somewhere in the 1970s, so almost till around 30, 31 years of 31 years, there was no data to suggest that KMC improved mortality. There's some data to say that KMC improved weight gain, KMC reduced DAMA, KMC improved maternal care, and so on and so forth. But there's no good data to say that KMC improved mortality. So this was the first systematic review, which kind of showed that KMC was associated with a reduction in the risk of mortality. And this was based on 16 studies, as you can see. And there was issues of improved breastfeeding, improved growth, and so on and so forth. As you can see here, what is this? The forest plot that you can see. There are two Indian studies that you can see in this forest plot. One is Kadam 2005 and Suman 2008. Dr. Suman Rao's DM thesis, which was, I think, done in 2003 or completed in 2003 or 2004, got published in 2007, 2008 in Indian Pediatrics. And when this was added to the earlier studies that were there, it kind of shifted shifted the balance towards improved mortality. As you can see in the forest plot, each of these lines cross the central line over here. So basically, it shows that each of these studies by themselves do not show any improvement in mortality. But when all of them are added together, looking at what the number of events are, that is there. So as you can see over here, the events here of mortality are 5 and 10 over here. And so these two studies kind of contribute a large number to the power of this systematic review. So this systematic review kind of pushed WHO post 2013 to invest a lot of resources into pushing for kangaroo mother care. WHO already had a book published in 2004 on how to do KMC and had some KMC related guidelines based on what the input they had received from the Pan American Health Organization, which works mainly in South America and in the US. So they had a book which was published in 2004, but there was no great push for using KMC across the world because there was no real evidence for it. But post this systematic review, actually before this in 2010, there was a systematic review published in International Journal of Epidemiology, which showed improvement in mortality. But that was not a Cochrane systematic review, and this was a Cochrane systematic review, so more rigorous systematic review, although the number of studies are the same. The International Journal of Epidemiology was published by one senior researcher who is currently a professor in, I think, Institute of Tropical Hygiene in London, Joy Lawn, and she published it in 2010 first, and then subsequently we had the systematic review from Cochrane. Prior to this, there were two systematic reviews or three systematic reviews in Cochrane, which did not show any change in mortality. So this was a study. This was published in 1997 October. And there was a prior randomized controlled study published by Natalie Charpak, I think in 1993 or 1994, which showed that KMC was useful and it kind of proved that KMC can be utilized. But this was a subsequent study which they did where they randomized 746 newborns. So remember this number, 746 newborns to KMC and to traditional care. So 382 KMC and 364 to traditional care. Again, this systematic review, as you saw in the previous chart over here, this 1997, did not show any change in mortality. So the risk of dying was similar in both the groups, and there were no difference in growth indices too. And nosocomial infections were more frequent in control infants. And so hospital stay was shorter in KMC, mainly for babies who are less than 1.8 kgs. So again, this showed that KMC was a safe approach and it provides necessary scientific support to a method that is already been used at many hospitals in the world. So it kind of provided some kind of evidence base. Now this same study, there was a follow-up, and this follow-up was published in 2017. So December 2016, it came online, and this study was actually discussed in our first KMC International Conference conducted by KMC Foundation in Hyderabad in 2017. I think it was in January or February that we had this conference, and then this study was discussed. This was the first study which actually showed that there was a improvement in brain volumes of KMC babies. So of those 716 participants of 746 participants of the original RCT, around 494 participants were traced, and 441 of the original RCT were re-enrolled, and results from 264 participants who are less than 1.8 kg were being analyzed. So this is a follow-up study, almost about 20 year follow-up from those babies that underwent KMC in that original RCT in Bogota, Colombia. So Natali Jarpak and others had published, the team had published a 1 year follow-up on these same babies in pediatrics, and they found that what was found in the 1 year follow-up was still present 20 years later in the most fragile individuals. So there is a fragility index which is there in that paper, which can be looked up. So they looked at very fragile individuals, and they found that these effects of KMC on 1 year IQ and home environment were still present. And as I said earlier, the brain of the parents. So the KMC parents were more protective and nurturing because they ensured that their babies, when the children went to school, there was reduced hyperactivity in the children, aggressiveness and externalization, and social deviant conduct of young adults. And neuroimaging showed larger volume of the left caudate nucleus in the KMC group. So this was a kind of a significant study, and in that study itself, in that study itself, they said that there will be subsequent publications from the same cohort that will come soon.
मेरा फोन अंदर ही है हॉटस्पॉट रखा है
Prashant Shit is talking. Can he mute? So again, so as I said, there was significantly larger cerebral volumes of gray matter, cerebral cortex, and left caudate nucleus. Interestingly, the volume of the left caudate nucleus was related to fragility. So if the fragility index was more, the larger was the volume. It was also dose dependent. So more the KMC you gave, the larger was the volume. And if you looked at fine motor skills, then better the performance, the larger the volume was at 20 years or so. So as you can see, so this is kind of the basis, the background, and this was actually presented by Aditya, but I'll be speaking about it. So this was a study that was come out of a Thrasher grant, received by Dr. Nisha Fahe, who is one of my mentees and who has been working with me since 2010. So I published a lot of papers together, and currently she's assistant professor in pediatrics at UMass Chan Medical School in Worcester, in Massachusetts. So this study was actually a follow-up study of a cohort of babies that we had discharged from 2010 to 2014 from our NICU. So we looked at in that paper in 2010 to 2014, which we published, I think, in 2015 in Acta Pediatrica. We looked at the number of hours of KMC received, how many babies in NICU received KMC, how many were eligible, did not receive, and so on and so forth. So we had this data set of babies that we had analyzed in 2015 and published. So we had phone numbers, etc. on this. So we followed up these babies. So this was around 10 years after they were born. So this happened somewhere in 21, 22. So basically 2010 to 2014. So basically 8 to 10 year old babies that were followed up. So one of my PGs did a dissertation on this, and she was helped by others in the collection of data also. So Binoy Shah and Axel Patel were MBBS students who, along with Dhwani Patel, who went to the villages in our surrounding area and interviewed parents and babies and collected data as far as the educational outcomes were concerned. So looked at the growth and the educational outcomes. So this was a Thrasher Research Fund Award. So the study hypothesis was that KMC compared to no KMC during NICU decreases the odds of mortality, growth failure, cognitive delay, and comorbidities among pre-adolescent children in our area. So I talked about the baseline cohort, which we published. So this was published in 2016 in Acta Pediatrica, and this was from 708 babies that were admitted to NICU between 2010 to 2014. This study again was done by an MBBS student of mine who was in a third year. She collected the data of this large number of babies, and we managed to publish in Acta Pediatrica. That student is currently now completed fellowship in neonatology in the US and interviewing for faculty positions in the US. So we had this data set that we curated, and we followed up this particular children. So as you can see on the iPad, they're doing sums, mathematics. So we contacted all of the babies via telephone. So out of the 708 babies or so that we had followed up, we actually had proper phone numbers of only 100 people, and remaining people we did not have phone numbers, but we had their village addresses. So we went to the villages, we searched the parents. Many parents had shifted to another village, so we went to the other village and searched the parents. So there was actually quite a lot of contact, reaching out to villages and contacting parents per se. So we looked at anthropometric measures, arithmetic and reading skills, and also health history. So we looked at all of this, and many of the patients actually had died. Many of the babies that were discharged actually had died, some in the immediate period and some after a few months. So as you can see here, there were 475 families of former neonates could be contacted. The remaining we could not contact at all. And as you can see, about half of them did not receive kangaroo care in the NICU. Now you would want to say that why they did not receive kangaroo care. So many of these babies were actually during that time. So ours is a paid NICU, and many patients cannot afford it. So what they would happen is, by the time they stabilize or before they stabilize, they would take discharge. Okay, so they would take discharge and then they would go. So they would not receive proper care. And the people who received KMC were 205, and one died before discharge from the NICU. And as you can see, the 270 who did not receive KMC, so they might have been critically ill, etc. And they around 32 died prior to discharge from NICU. So finally, we had 238 who did not receive kangaroo care, and 204 who did receive kangaroo care. And when we looked at follow-up, 24 had died in the KMC, what do you say, cohort, and 106 had died in the non-KMC cohort. And a few, 7 people did not participate in the study. And so we had 179 completed visits in the KMC cohort and 126 completed visits in the non-KMC cohort. The age group, as you can see, the average age was 9.4 in this one and 10.1 in other. Very interestingly, as you can see, there is 50% female in the babies who did not receive KMC. So basically, babies who got discharged earlier do not remain in the NICU, and 30% in those babies who received KMC, and so basically who accepted treatment in the NICU. So there's a male preference that you can obviously see in the cohort. So what we found, there were 55% higher odds of ability to add numbers when they did KMC. 56% higher odds to read words, 38% lower odds of anthropometric failure, and no difference in having a comorbidity. So there was a 39% lower odds of cognitive delay in those babies who were receiving KMC, and 55% lower odds of composite adverse outcome among alive children. So basically, and there was 83% lower odds of mortality which was there. So there was a positive effect of KMC in our followed up patients which are there. We looked at DAMA versus non-DAMA, and as you can see in DAMA, there is a higher level of death which has happened, which we explained earlier in the chart that we saw. So there were, because this was a cohort study, there were dropouts and so on and so forth. So there was a lot of statistical analysis that was done. This was mainly done from the UMass participants. There was fragility index adjustment which was done. There was a propensity score adjustment which was done. There was a multivariable adjustment which was done. Despite doing all of this, there was not much change despite the sensitivity analysis, and so there was no much. While there were study limitations, it was expected that even if the limitations were not there, the results would have been still the same. Okay, so in short, KMC in our NISU is associated with improved cognitive ability, decreased anthropometric failure. So basically, decreased malnutrition and decreased mortality at 10 years of age. We can look at having advanced epidemiological methods to generate more rigorous evidence of life-saving interventions using existing real-world data. And impact of KMC and mortality is strongest among those that were discharged against medical advice. So even those babies who received KMC, there was better. So we will want to look at dose response of outcomes based on intensity of KMC during the NICU stay. This was one study. So we have many more studies, but we will just describe a few in brief. So we have this published in Indian Pediatrics in 2000, I think 23 or so. This was one of our NICU fellow study where we had 40 clinically stable preterm neonates which were admitted to the NICU and who received KMC. We looked at their physiological and cerebral blood flow parameters, and it showed various indices. I'll not go into details. This is a published study which shows that there was an improvement in KMC, and 60 minutes after stopping KMC also, all parameters were higher than baseline, indicating a good positive post-KMC effect. So the conclusion was KMC improves cerebral hemodynamics in clinically stable preterm neonates. This is another study where we looked at the effect of skin-to-skin contact on cerebral blood flow during the first hour of life, that was skin to skin care compared to baseline values. Again, there was a significant improvement at 60 minutes after birth, after 60 minutes of skin to skin care from baseline. So again, this is not an RCT. This is just all babies that who were born and who received KMC or skin to skin care at birth. They showed better brain parameters. So again, this is the graph of that particular study. Okay. There are other studies, and we have published a lot of studies on neonatal pain. Suffice to say that KMC reduces the scores of neonatal pain, and so basically reduces pain in the newborns. Why is this important? Because there are studies to show in animals as well as in neonates that neonatal pain has long-term effects. Animal study shows that whenever neonatal pain is given to animals and the brains are dissected and you look at the neuronal connections are very poorly formed. So in effect, it says that if you don't control neonatal pain, the neuronal development is poor, and that is seen in children or newborns who receive painful procedures. They have a hypersensitivity in the skin long after they have been discharged in the NICU, even in the childhood and adolescent period. So this neonatal pain, if we don't prevent, it will definitely cause brain-related issues to some extent. We are looking at AAEG changes in stable preterm neonates also. Okay. So how does KMC improve brain function? So there, as I said in the forest plot for mortality, there is no evidence or systematic review to show that KMC improves brain function. Why? Just because there are not enough studies, there are not enough follow-up studies that are published which show this particular effect. Like in KMC, it took almost like 35 years for evidence to emerge that KMC improves neonatal mortality. And subsequently, maybe 10 years later, we know that IKMC even improves that neonatal mortality even further. So in a similar way, we believe, and there are some studies to show that KMC improves cognition and improves brain function in the neonate. But there is no systematic review if you go and search and find it, because it will not show, because we do not have enough studies to have that effect as yet. So why is there improvement in KMC and the brain? How does it affect the brain? So there are these various senses. So if you look at DSC or developmentally supportive care, all of those measures that we do are basically to improve the development of the brain and to improve intact survival. Now, whenever you do developmental supportive care, we basically stress on sleep, touch, smell, stress, and pain. So we talked about some of this. All of these are improved by KMC. We'll see how it is. KMC definitely improves breast milk production. There are lots of studies which show that it increases the volume of breast milk production. It increases the duration of exclusive breastfeeding. the number of mothers who do exclusive breastfeeding increases with KMC. It improves the duration of breastfeeding. So 2 years, 2.5 years, 3 years. So it increases the volume and so on and so forth. So there is lots of positive effects of KMC on basically skin to skin care on breast milk production. There are quite a few studies which show that KMC improves the parental mood activity and reduces maternal depression. Why is that important? Because all of this have impact on neonatal care, and a mother and a family which is less stressed, which does not have postpartum depression, will take better care of the baby and thus improve the outcomes of the baby. So that is the brain of the mother and the father, that how KMC kind of affects. So all of these have effect on the formation of neural connections. I talked in detail about pain, but the other parameters also do affect neuronal connections. We'll talk about sleep in a bit. And when any of these are disordered and they are not proper, they lead to poor neuronal connections. Okay, so KMC modifies all of the above parameters and thus can affect neuronal plasticity. We talked about breastfeeding and I have talked about this. And we do know that breast milk improves IQ points, and it will also improve KMC, and that KMC also will improve IQ points. So one of the ways in which KMC improves IQ points is probably through the effect of breastfeeding. But there are the other things that we have also looked at. I talked about this already. So more stimulation in newborn via talk, singing, movement, etc. So if the parents are not anxious or depressed, especially the mother does not have postpartum depression, she is likely to interact more with the baby. And we know that, and this actually works across the lifetime of human beings. The more interactions you have in life, the more better you will become. So whether it's a newborn, whether it is a teen, or whether it is an adult, the more interaction that you have, the more successful you are likely to become. So this is very important and that is how the brain works. It's basically more exercise for the brain and the brain becomes better. That's to put it very simply. Now we looked at, we talked about sleep earlier, and we'll talk about that in a little bit more detail. So KMC has significant effect on sleep organization, and in that way it affects brain maturation and brain complexity also. So we know that sleep has various phases, quiet phase and active sleep. So quiet sleep and active sleep, this will come again and again in the further studies that I'll discuss. And it is important to understand what all this means. And the quiet sleep is crucial for creation of long-term memories and learning. And the REM is a critical component associated with development of various systems. So we need to have both of them in appropriate amounts. Now, a sleep cycle is very important for sensory system development and also important for creation of long-term memory and learning and preservation of brain plasticity. We all know, and if there are residents listening, that if you don't have a proper sleep in the night, next day when you're around and you're answering questions to your consultant, you're very likely to be wrong or you'll forget some things. And same reason that we say that when you study for exams, when you're giving exams, it's better to have a good sleep during the exam time. So sleep deprivation is the same for newborns, and if it happens even in the fetus and neonate, has profound effects on early sensory development and creation of permanent neuronal circuits for the primary sensory systems. This line talks about fetus. We will not go into fetus, but there is enough evidence to show that if there are problematic events when when the fetus is in utero and mother faces problematic events, there is enough evidence to show that it impacts the fetus growth as well as its long-term outcomes for cognition, etc. But we'll not go into that. But the point is that it affects there too. So sleep is not a passive process. There are various cholinergic cells which stimulate sleep actively. There are various EEG waves that happen during REM sleep, and they have a specific role in sensory system development. And REM sleep deprivation between 30 weeks gestation and 4 to 5 months. So it's a big stretch, big number of months. So it's almost like 8 months. Results in delayed or disordered development of the various sensory systems that we discussed. in the NICU. When I ask this question at conferences or in workshops as to how much the baby sleeps in the NICU, most of them get it wrong. Okay. Babies in the NICU barely get 10 to 10 seconds of quiet sleep. Okay. Which means their sleep is disrupted mainly because of separation from the mother and poor caregiving environment. So when your sleep pattern in the NICU is chaotic, and we discussed earlier that we require good sleep for good brain development and for us also, then that is not happening in the NICU. When the baby is on KMC, it increases the quantity of quiet sleep. We discussed quiet sleep and active sleep. It increases the quantity of quiet sleep. There is a non-chaotic sleep pattern. There is good sleep cycling. And also, again, when I will discuss in a few slides, when I ask the question, how long is the sleep cycle in a neonate? Most people get it wrong, or most people don't know the reason why we say minimum 1 hour of KMC. The minimum 1 hour of KMC comes because the sleep cycle of a preterm baby is around 55 minutes to one hour. So if you give 1 hour of KMC, then you're likely to get a complete sleep cycle. And the KMC Foundation generally says minimum 1.5 hour. The reason being, different people interpret 1 hour differently. So somebody might interpret from the start of KMC, from putting the baby into KMC to removing the baby from the KMC, which kind of adds 5 minutes on either side. So basically, baby might get KMC of 45 minutes to 50 minutes, which is not enough for the sleep cycle to get completed. So we generally tend to say 1.5 year at least if you want to say that proper KMC is being given. There are less sleep arousals, heart rate, and respiratory variation according to sleep cycles also improve. And as I said, it takes around 60 minutes to complete. And usually within 5 minutes of putting the baby on KMC, sleep cycling begins. Baby goes to sleep and sleep cycling begins. Okay, and cycling is needed for normal growth. We discussed this significantly. There are studies which show that preemies in incubators demonstrate poor sleep cycle patterns throughout hospitalization, and a result of delay in sleep cycling affects post-discharge sleep for up to 2 years. So these are published studies which show and which have used EEG patterns to document sleep cycling, and they have found that poor sleep cycling in the NICU can persist for up till 2 years. So not only does the brain development get affected during the stay in NICU, it continues to get affected even after the baby is discharged from the NICU. Hence, it is important to ensure that babies in the NICU get KMC for long durations of time. So this is a study that was published in 2006. This is one of the earlier studies that was published where EEG was used. This is Ludington Ho et al. She had come to our international conference in 2012 when we had done it in Ahmedabad. And she is one of the pioneers of EEG studies. She and her team have published multiple studies of EEG and KMC. So she has taken quite a few lectures for our KMC conferences too, mostly online, and once she had come here physically in Ahmedabad. So this looks at the effect of skin to skin contact on 5 neonatal sleep organization features. This is published in pediatrics and is mainly at postmenstrual age of 32 weeks. The control infants were in pre-test incubators, while the skin to skin care infants were positioned with with the mother in a recliner in a lounge at 40% incline by the side of the incubator. So, and they looked at, again, as we discussed earlier, quiet sleep, active sleep, and indeterminate sleep. This were done through visual scoring of EEG continuity. Now, this same group has not only done EEG interpretation in the normal way, but they have used in complicated parameters to analyze the same EEG waves and interpret differently, which I will show in a further few slides. So they found that benefits of skin-to-skin care was there on neurophysiology, organization of sleep among babies who were preterm. There was a reduction in arousal, so good sleep continuity was there, both in quiet sleep and as well as active sleep in the skin-to-skin care group and throughout the skin-to-skin care period. There was the changes in sleep organization, that is decreased arousals, REM counts, and indeterminate sleep, increased quiet sleep percentage. All of this will may promote improved brain maturation. And so in many ways, skin-to-skin care is a non-pharmacological intervention treatment that positively affects sleep organization and ultimately neurodevelopment. Remember, this is a study published not almost 18 years ago, in 2006. This was subsequently followed in 2009 and by the same group, Scare and Ludington Ho et al. So in the animation slide of sleep which I showed, you saw a paper from Sher et al. That was published in 1997, which documented that poor sleep organization in the NICU persisted up till 2 years of age. So that same group looked at this particular study. So what they did is babies got skin-to-skin care for 8 weeks, and they looked at 16 EEG sleep studies that were performed on 8 preterm infants who received 8 weeks of KMC and compared with two non-skin to skin cohorts. So one was a term cohort and one was a preterm cohort. Okay. So you got preterm babies who got skin to skin care, you got preterm babies who did not get skin care, and you got a full-term babies who were again kind of the control. So preterm babies with skin to skin care, preterm babies who again, so all of this were tested at around term gestation. Okay, and what was noted was quiet sleep, non-REM sleep, active REM sleep, and indeterminate sleep. So all of this was checked. What they found, there was fever and MI movements, more quiet sleep, increased respiratory regularity, longer cycles, and less spectral beta were noted in the skin-to-skin care preterm infants when they were compared with both control cohorts. So the preterm babies who did not receive skin-to-skin care, as well as the term babies who were of 1 to 3 days of life. So during that time, fewer REMs, greater arousal, and more quiet sleep in skin-to-skin care infants, that preterm infants, compared to the non-skin-to-skin care preterm infants. They looked at complexity of the EEG waves, and they found that there were 3 right hemispheric regions had greater complexity in the skin-to-skin care group. When they mean greater complexity, basically means more neuronal connections, and so basically it shows that the skin-to-skin care babies had better neurologic organization. So discriminant analysis, so some form of complicated analysis that they did showed that the skin-to-skin cohort was closer to the non-skin-to-skin care full-term cohort. Okay, so what I'm talking here, where we have assessed, they have assessed using EEG, is also shown. I'll show the slides later on in the Colombian preterm infants, where they compared the preterm babies who received KMC versus the preterm babies who did not receive the KMC, and they had term controls, and they looked at speed of neuronal transmission of electrical impulses. There, in that study that was published in Acta Pediatrica in 2012, it showed that the preterm infants who received KMC had the same speeds through transcranial magnetic stimulation as term babies, and this was at adolescent age group. So what here they are showing at 8 weeks of skin-to-skin care in preterm infants, where they found they were similar to term babies. When they use transcranial stimulation, magnetic stimulation in adolescent, this kind of effects persisted. So skin-to-skin care contact accelerates brain maturation in healthy preterm infants compared with the two groups without skin-to-skin care. And this is that 8 weeks of after 8 weeks of skin-to-skin care. This is in prematurity or around term gestation age groups after receiving 8 weeks of KMC. This is again, they had used neonal, they had used another analysis, which is discriminant analysis, as you can see, from the same babies. So the previous study, as you can see, was published in 2009. They used the same EEG data and they published it in 2013. So you can see that the number of babies are similar. 16 EEG sleep studies are performed on 8 preterm infants who received 8 weeks of skin-to-skin care compared with 2 non-skin-to-skin cohorts. One of them was a preterm baby and the other was a full-term group. So it was 1 to 3 days of life. They use something called as time series measures of predictability for comparisons. And the skin-to-skin care premature neonate group had increased complexity when compared to non-skin-to-skin care premature neonate groups. So what I said earlier also persisted, and when they did even more neonatal EEG complexity studies. So what it kind of shows is that kangaroo care intervention accelerates neurophysiological maturation of premature neonates. This time series methods quantify predictability of EEG sleep in neonates and can be used for useful information. They use complexity measures such as approximate and sample entropy, which can be used to quantify brain maturation. So again, brain maturation is a neurodevelopmental process that can be facilitated or improved by skin-to-skin care. This is published in 2014, and so we have seen MRI studies in the 2017 publication in pediatrics. We have seen some EEG studies. We have seen our cerebral blood flow studies that was done in Karamsad, and we have seen a 10-year follow-up that was done in Karamsad. Now we are seeing, and there are many studies like this. But so I picked up one to show. There are some at least 3-4 more that have been published. One has been recently published in the Journal of Neonatology, where they looked at cerebral blood flow parameters. Here they have looked at 60 preterm stable infants who were assessed before and after 30 minutes of KMC. And again, so they have looked at different positions before KMC. They have done in supine position, vertical position. And so what they basically show that when they looked at pulsatility index and resistivity index before and after KMC, there's a significant decrease in both pulsatility and resistivity index after 30 minutes. Increase in end diastolic velocity and minimum velocity after 30 minutes of KMC. And these changes indicate improvement in cerebral blood flow. So there was no correlation between CBF parameters and vital signs or SpO2. So again, they conclude that KMC improves cerebral blood flow, and hence by improving cerebral blood flow, it might influence the structure and promote development of the premature infant's brain. So this is using cerebral hemodynamic studies. We have looked at EEG studies where they have shown that it can improve the neonates, premature neonates brain. So this is image from their study. As on the left hand side, you can see before KMC, as you can see higher resistive index. You can see resistive index dropping over here. Okay. So both decrease in both PI and RI after 30 minutes of KMC. Okay, this now we come to what is cerebral oxygenation. So needs where oxygenation is, there are different ways of studying the brain. So we looked at EEG, we looked at MRI, we looked at transcranial magnetic stimulation, we looked at cerebral blood flows, and here there is cerebral oxygenation. So one of the issues about KMC is when people and so this is kind of when babies go to KMC, it was felt that the baby might remain in a poor position, and because of neck bending or whatever, there might be poor cerebral oxygenation. So that was one of the ways that, and so this studies was done to find out whether when the baby is in KMC, whether cerebral oxygenation drops. Okay. So what it showed, as you can see in the second last line, the skin-to-skin care does not lead to an increased number of bradycardic and hypoxic events or a longer time spent in cerebral hyperoxia or hypoxia. And the change in position from supine to prone and the angle on the mother's father's chest during skin-to-skin care does not influence cerebral oxygenation. So they looked at incubator care for 90 minutes for the same babies versus 90 minutes for skin-to-skin care. So basically, each infant acted as its own control, and caregivers, that is the pediatricians who did the study, did not know the reports of the cerebral oxygenation, to RST-O2 measurements. So there was skin-to-skin care led to reduction of RTS2 by about 8%, which is not of clinical importance. This is another study. So this was a study published in 2018. The study published in 2021, where they looked at maternal singing combined with skin-to-skin care. Okay. They found that the mean RTC-SO2 for the 31 preterm infant showed a significant increase from baseline during skin-to-skin care music session versus skin-to-skin care post. So this is how you can see. So this baby is in skin-to-skin care. There is a person playing guitar, as you can see, some live maternal singing. So mother is singing accompanied by a live guitar music with infant in the skin to skin position. Mothers were asked to remain silent during pre-skin to skin care and post-skin to skin care. And during skin to skin care, they were asked to sing. And maternal singing of simple, repetitive, soothing songs. And so they looked at this various volume, etc. So volume also is between 55 to 65 decibels. So what they found, music therapy with skin to skin care caused a modest increase in RtCO2 and a decreased coefficient variation of RtCO2, so which suggests basically short-term benefits for preterm infants. So we looked at another thing. Now we are looking at parent training with KMC, whether it impacts infant neurological neurophysiological development and mother-infant neuroendocrine activity. So this was an RCT to see the effect of KMC in mother-infant diets on pattern on infant brain activity and associated mother-infant neurohormone releases. So 33 mother-infant diets participated during pregnancy, that is 29 to 38 weeks gestation at neonatal and 3-month period. So infants in the kangaroo care group showed left frontal brain activation patterns associated with kangaroo care training. There was a moderate to large increase in oxytocin levels, that is the neuroendocrine activity, and kangaroo care yielded moderate decreases in cortisol reactivity. So this suggests that kangaroo care would garner favorable neuromaturation and neurobiological outcomes of for diets. So this is another study which was related to delirium. So there are two studies I think that are there in this which are related to delirium. Okay, so this was again delirium. So this is the same study. There are two publications. There are effects of 60 minutes of delivery room skin to skin care contact compared with 5 minutes of visual contact. And this 5 minutes of visual contact does change the brain activity. And so there is a separate publication which is related to this. So it looks at mother-child interaction, salivary cortisol, maternal depression, stress, and bonding at 6 months of corrected age. So they looked at 60 minutes of delivery room skin to skin care contact compared with 5 minutes visual contact. Okay, and they looked at 88 preterm infants, and out of which 45 infants were allocated to delivery room skin to skin care and 43 to visual contact. And visual contact also has good outcomes. Okay. So delivery room skin to skin contact diet showed a higher quantity of maternal motoric, infant vocal, and motoric responses. Okay, combined score of maternal and infant response behaviors higher in the delivery room skin to skin care diets. Delivery room skin to skin care mothers had a lower risk of both early postpartum depression and impaired bonding. Remember, this is just 60 minutes of skin to skin care in the delivery room and not further. So even that had a lower risk of both early postpartum depression and impaired bonding. So delivery room skin to skin care promotes maternal child interaction and decreases risk of maternal depression and bonding. And thus, they say that delivery room skin to skin care may have positive effects on preterm development. So this is one study, and this same study was later analyzed, and so this is the same study. So preterm infants between 25 to 32 weeks of gestation, when they were birth, they were randomized to 60 minutes of delivery room skin to skin care or 5 minutes of visual contact, which I've described earlier. So this is a different publication, but the same babies. Self-reporting questionnaires were taken from the parents at third day of life. And at discharge, blood was taken for gene expression. So cortisol reactivity, self-reporting questionnaires for depression and short-term clinical outcomes. And as you can see, at 6 months corrected age, we had done this mother-child interaction and self-reporting questionnaires. So this particular paper looks at for the gene expression. So this effect of delirium skin-to-skin contact on the infants, mRNA expression of 6 key molecules that were looked at. So gene expression of CRH2 correlates with HPA axis activity and mother-child interaction at 6 months of age. So what it again says is that delirium skin-to-skin contact might affect long-term stress response via regulation of gene expression, and delirium skin-to-skin contact might contribute to improved outcome of prematurity. So I mentioned earlier on fetal and neonatal stress and how fetal stress can contribute to changes in behavior of the neonates, not only in the neonatal period, but beyond. So what is called as epigenetics. So epigenetics is not restricted to effect of maternal milieu, maternal thoughts, or maternal behavior on the fetus. It happens even after delivery, and this is what you are seeing in this particular paper, where even delirium skin to skin contact for 60 minutes can affect gene expression in babies. This is a further study which looked at is a meta-analysis. This is again for premature mother's anxiety and stress state. So this is a meta-analysis. So this suggests that skin-to-skin contact can effectively relieve anxiety and stress states among postpartum women of premature infants. And there is significant but limited evidence that skin-to-skin contact for at least 1 hour per day has a protective effect on anxiety states. But in a peculiar way, this says that if the intervention exceeds 2 weeks, then this may not be true. So this is kind of a meta-analysis which is not very complete, but suggests that skin to skin can kind of improves mother's anxiety and stress states. This is another publication. So this is another interesting long-term follow-up publication. This is published in Proceedings of National Academy of Sciences in 2021. Very interesting study. They looked at a 2-decade follow-up. So preterm and full-term neonates who received or lacked initial maternal bodily contact and repeatedly observing mother and child social synchrony were followed. They were as you can see over here, they were these 3 groups: full-term, kangaroo care group, and the standard care group for preterm babies, and they were followed up. They were followed up by at during infancy, preschool, adolescence, and young adult. So we can see that there were questions that were given to the adolescents at various points, and they looked at the responses, and they have scored the responses. It's a little complicated study to kind of explain, but suffice to say that this was a long-term follow-up study. And what it shows is that proximity to the mother's body in premature neonates during the period of incubation is linked to enriched caregiving in humans, similar to what happens in other mammals. And this initial improvement is seen throughout the course of the child development, suggested by sensitive period perspective. So what happens during the neonatal period influences the outcome on the child and the parents up to even adulthood. So this is what I wanted to kind of share. So the carrying patterns, that the early carrying patterns stabilize across lengthy developmental epochs and over time impact brain functioning. So this shows how human relationships are gradually represented in the brain. So there are findings show that the long-term effects of maternal caregiving in humans are similar to the role in other mammals, particularly in tuning core regions implicated in salience detection, simulation, and interoception. So if you look at mammals in general, when our caregiving for our progeny is better and there is improved caregiving, this kind of persists throughout life, and so that is the reason why, especially in India, there is a lot of what do you say, the mammal which is not very closest, but which we live with for a long duration of time, which is the cow. There is a lot of reverence for the cow, specifically because of this, because cows also do similar caregiving, and you can see the bond between the calf and the cow, which is kind of expressed in many of our what do you say, ancient literature. So you can see this literature being kind of shown in studies in human beings also. This is another report, which is a more recent report in 2022, which looked at anxiety, stress, fatigue, pain, and delivery related post-traumatic stress syndromes. So it again shows, which I have explained earlier, that daily skin-to-skin care in healthy mother-infant diets may reduce anxiety and fatigue symptoms, but not depressive stress and pain symptoms. So this is something which was published. Okay, this is coming back to Dr. Natalie Charpak's paper. This was published in Acta Pediatrica. Paper which is similar to this paper has been published in Journal of Neonatology in the KMC edition in this June in the Journal of Neonatology. They looked at the long-term impact of KMC on brain volume and its association with cognitive development. So they published in 2016, 2016 December, how fragility index, when babies had it high, KMC improved their neuronal outcomes. There was more brain matter in the caudate nucleus, etc. When MRIs were done. Now they have followed this up, and they have from this similar data, they looked at 20-year-old adults who had been born preterm and had taken part in the. So this is the same cohort of babies that was there, the 746 preterm and full-term babies who are born weighing less than 2 kgs. And in this particular study, they had 433 babies. So this is basically the same study, but this is a different kind of analysis that they have done. So they looked at cerebral volumes of gray matter and white matter and organization of white matter. So they have used the same data, but they have done a different kind of analysis using neurological and neuropsychological tests. And they had this MRI data that they had collected in 2016-17. They had more complicated analysis of that MRI data, which was done by expert neuroradiologists. So that is explained in this particular paper using various how it was analyzed. So you can see this thing about free surfer image analysis suite. You can see Dracula and free surfer to obtain main white matter pathways. So they looked at independent neuronal pathways in the brain with various what do you say, complicated software. And you can see that there is this interactive visualization of data was performed using Brabis based on R software. So basically the same MRI images that they had got. So you could say this is AI, but they're basically kind of examined that data in more detail, and they have published this paper. So again, here they show that the KMC groups, and they have looked at specific areas of the brain matter. So earlier we talked about a few caudate nucleus and how things improved overall in the MRI, but here they have looked at separate areas of the brain function and how that separate areas of the brain function have improved using the same particular data. So the KMC group had larger volumes of total gray matter and cortical gray matter and subcortical gray matter in the striatum, caudate, and putamen nuclei. That's a significantly higher volume of corticospinal tracts. They had no differences in total fiber length or total fiber count. When they looked at cognitive function, because they have not only done the neuroradiologic analysis, but they have also done this tests of IQ in this adolescents. This analysis showed that the total brain matter, total cortical gray matter, and the IQ test, there was an association between the duration of KMC and the total brain gray matter. Interestingly, this talks about how every day of KMC, for each day of KMC, the volume of the total gray matter increased by about 0.15 millimeter after adjustment for severity index. Okay. You can see here again for the subcortical gray matter, it showed that if for every day of KMC increase, there was an increase in 0.15 millimeters of KMC. Again, the same for caudate nucleus and putamen, where it increased by 0.19 millimeters. So they have looked at each and every anatomical structure, and they have correlated with how every day of KMC, how much that uh, the white matter or the gray matter kind of increase. They looked at memory and attention, and they so that for each day of KMC, the volume of total subcortical gray matter increased by about 0.16 millimeter, and it was controlled for the severity index and the California verbal learning test. So they looked at how memory and attention correlates to brain matter too. They looked at again fine motor skills and coordination, and again here you can see that there is a correlation between each day of KMC and how there is an increase in the volume. So it's a relatively complicated paper, and if you look at the paper in Journal of Neonatology, also it describes in much detail. So what it kind of concludes, it concludes that the protective, nurturing, neuroprotective effect of KMC persists into young adulthood. There's an independent positive association between the duration of KMC and the volumes of various gray matter basal nuclei at cerebellum and the organization of white matter. So almost every part of the brain. These structures are involved. Now, why it is important? Because these structures are involved in both minor and severe sequelae that are typical of prematurity, such as IQ deficits, problems with attention, memory, fine and gross motor skill, and coordination. Okay, so KMC induces a long-lasting protective effect against the various deleterious effects of being born too soon. So KMC is something which affects the brain in a significant fashion. So this is more detailed analysis of the study that they had published in 2017. A subsequent study, this is a pilot study looking at functional activation of preterm's newborn cerebral cortex during kangaroo mother care. So this was again studied by NIRS, or near infrared spectroscopy, and they looked at oxy and deoxyhemoglobin variations. What it shows is that KMC seems to benefit activated cortical areas by improving oxygen supply. So very significant ways that it affects the brain. So there are few more studies which I have not covered, and I think I have taken exactly about 1 hour for doing this presentation. But I would like to bring home the point that there are lots of evidences which show that there is an influence of KMC on the child's brain, and we have looked at various ways in which the brain has been evaluated. EEG studies, cerebral hemodynamic studies, cerebral oxygenation studies, behavioral studies, fMRI studies, intelligence scale, and so on and so forth. There are studies which have looked at maternal and paternal effects, anxiety, depression, bonding status, how they take care of babies, etc. So in all, there is a lot of evidence which shows that the more KMC is given, not only does it improve neonatal mortality, it has long-term effects on the brain, which persist into adulthood. And definitely, if we track these babies till they die or till they become grandfathers, probably it will still impact the brain. So, the hallmark of any neonatal intervention uh, is that we need to follow up that effects on the intervention at 1.5 year of age, 5 year of age, 11 year of age, and here they followed up to 20 years and beyond. So I would like to thank all the people who did the studies, because this is a very significant uh, understanding that we need to have, that KMC is not just for poor people, but that's what generally people started. तो अपने पास तो incubator है or whatever, it doesn't really affect. The incubator will not replace KMC in any way, and it is not a good thing to have at all. So, and KMC is not for poor. KMC is not a poor man's incubator. KMC is something which will benefit, and it's a gift that keeps on giving in many ways. I would like to thank you all, the people that who remained for listening to this patiently. Thank you very much.
Thank you so much, sir, for elaborate review, and it was really inspiring. So much work still we can do in kangaroo mother care. These were just a very few sample size, RCT. There is so much volume for Gujarat to do such studies. And I think we must do some multi-centric, because all the government facilities are there, as well as the private or the semi-government facilities also, where we can put our data, our findings, and we can come up with our experience sharing. For so much work of research we can put for the kangaroo mother care. And indeed, a kangaroo mother care is a multimodal stimulation technique which has lot of impact on the preterm new low birth weight, as well as like recently I did on full term also, sir, where we could see the improvement in the latch score. Within first 48 hours, we gave a kangaroo mother care to the full term newborn, and there is improved successful breastfeeding rate have increased. So, and the other component, like it is a 360-degree evaluation. The parents are also impacted so much. Thank you so much. Vishal, you are there?
Yes, ma'am. Thank you so much, ma'am. Thank you so much, sir. It was like excellent presentation from your side, sir. And rightly said, sir, by sir, that it is a non-pharmacological treatment. And sir presented lots of evidence, and now we have no any, loopholes to, continue the KMC. So we should keep doing a KMC. Of course, we should increase the time, and as sir mentioned that it not only decrease the mortality in neonatal period, but also long-term outcome, decrease the growth failure rate, improve the cognitive function and cerebral hemodynamics, lots of new things, and also improve the sciences. And I like the presentation, like sir's like sleep improvement, which is like more important thing in the NICU. It is a huge impact on that one. KMC with the musical therapy. That's also new thing is coming. So it's all intervention can improve the long term outcome. Of course, there is another benefits for the parents, like it improve the decrease the anxiety, decrease the rate of the depression, and improve the so there's a lots of advantage. So thank you so much, sir. I think there would be any question from chat. Let me check, sir.
There is no question. I think there is no
No
question.
question. Thank you so much, sir. It was very nice, sir.
I really
Very
enjoyed because I initially it's a long presentation, but I think it is important for people to understand
Nee.
many things.
And sir, I wanted this presentation to be part of NNF Pathshala YouTube video so that it can be repeatedly reviewed if because when we put some research idea or if we want to talk to the residents, they can go look back to this video and they can whatever interest for developing a research, they can definitely like design their protocol. So amazing talk, sir. Thank you so much, sir.
Thank you very much. Yeah.
Sir,
Thank
I
you.
have one more question. Like so once like small question. Like when mothers are doing KMC, they are keep looking the mobile. I don't know how much it affects. We frequently tell our parents that don't. You can read it or you can listen the music. What impact on the mobile? I think you can do that research for in the current. So maybe I don't know.
એટલે શું કરીએ મોબાઈલ જુઓ કે ના જુઓ એવું
So the general
Yeah,
thing
I
about
don't know. I think this is like frequent, and like parents who are doing together, like we have like 6 to 7 KMC together, and one parent in company they see just looking the mobile. I don't know how much impact on her baby. A baby might sleep in downstairs. Very small, maybe 600 gram. We are giving KMC with the ventilator. So that's a thing. I don't know how much impact of the mobile. So
So
any thoughts on that one, sir?
so mobile impact would so the point is there is this what is it called? Uh, um, this addiction, internet addiction or syndrome or whatever. So the point is, we published a paper some time back, and this is in school children. We found that there is no addiction to the net if you don't get addicted if you search for information. So basically, if you read interesting stuff on the mobile or on the net or laptop, wherever, if you are searching for information, you do not get addicted. So basically, you're learning. But if you're doing reels is something which is a problem.
addiction
It is just
Addiction.
pure addiction, and there is research which shows that reels changes the brain waves. So I think definitely it will and it's
sir
very
please share, I'll share with my teenagers. Please do share that.
so I think it is very important. So पुराने जमाने में थे ना कथा थे ये थे all those were very important. So there is research which shows that if you have fast moving images it affects the brain formation. But if you are looking at a like if you're watching TV, if you have these fast moving images like all this Naruto and all this Japanese whatever, those are not good for the brain. But if it is a story like it's like a movie or a story like a slow story which without any jerks in the presentation, that has better effects on the brain. So what kind of movies you see or what kind of video you see also is impacts the brain.
Yeah, thank you so much, sir.
Thank you, sir.
Thank you. Yeah, bye.
Thank you so much, Shankar sir, for the excellent presentation. It was really an in-depth and research-oriented presentation. Thank you, sir.
Thank you.
Thank you, Ishan, for excellently moderating this session. Thank you, Shwetal ma'am, for being there, and thank you all the delegates for being there throughout the session. Thank you, Clear, for the seamless experience.
Thank
Rupsa,
you.
we can end the session.
Thank you so much, sir, for providing us the opportunity to host this session. So with this, we are closing today's session over here and looking forward to host you again. Thank you so much, everyone.
Thank you. Yeah.